everyone. Welcome to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Tercera Therapeutics. My name is Rain Bennett. I'm your host. I'm a filmmaker that's been working with CCF for almost 10 years. It's hard to believe, but it's been such a pleasure to do the work that we do. And what we try to accomplish is we create video content, live video series like this, and produce videos that we do as well, treatment-based, patient-based, that all seek to achieve the same mission, to spread awareness and education about neuroendocrine tumors. That is what we are trying to accomplish. So if you are new to the program, let us know where you're signing on from in the world. We love to see how far these programs reach, and inevitably, even though it's noon Eastern time, people all over the world tune in live, and that's so exciting for us. So we appreciate that. And if you're a regular, hello and welcome back to the show. You know what to do. Let us know where you're from. First of all, before we get started, we always want to thank our sponsor, Tercera Therapeutics. Without their support of Luncheon with the Experts, we wouldn't be able to put this show on. So very grateful and thankful for them. And always, we like to include this quick disclaimer from them that says the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, have not been created or suggested by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any health or any choices they make about their health or treatment. So that last line is always the takeaway that I want you to latch on to. You know, sometimes with disclaimers, there's a lot of legalese and it's easy to get lost. Listen, we're going to give you some general advice, some direction. We're hopefully going to answer some of your questions, but our guest doesn't know your specific case. So take that information back to your home team who does know your specific case, and collectively together make the best decision for you going forward. As you all know, this case is very unique for each and every patient. So very excited about today's show. Our guest is Dr. Boris Naraev. Dr. Naraev, how are you?
Good, thank you. How are you?
I'm doing very well. It's good to see you again. So tell us a little bit about yourself, where you work, what your role is there. How long have you been working with neuroendocrine tumors?
Well, I'm a lead of the Neuroendocrine Cancer Program here at Banner MD Anderson Cancer Center in beautiful Phoenix, Arizona. And I've been involved with neuroendocrine tumors for more than 10 years now, after I started my fellowship training at the University of Iowa, which is one of the well-known centers in neuroendocrine oncology. And I was trained under the guidelines of Dr. Odorisio, Dr. James Howe, and Dr. Thor Havdanarsson. So, and now I'm helping to treat patients with neuroendocrine cancers here in Arizona.
Yeah, and shout out to Dr. Havdanarsson, who was on the show very recently. He is a friend of the foundation and an amazing expert in this disease as well. So you started about 10 years ago. What would you say led you to this disease? What were you doing before, and what was that transition?
Well, it was sort of natural transition because it was fellowship training. I was reasonably new to oncology. And when you are exposed to great teachers like Dr. Odorisio and Havdanarsson and Dr. Howe, and when there is natural exposure to so many patients, because University of Iowa is a well-known center and many patients come in there. So it was natural interest. And of course, it matters when personalities click. Talking specifically about myself and Dr. Havdanarsson. So, and it led to many great research projects.
Absolutely. And we've done some work at Iowa as well with Dr. Odorisio and Dr. Howe. So also they've been amazing. Florian from Germany, Elena from Moscow. So you see, this program reaches all over the world, even though we're live here in New York time. So if you're not familiar, if you're joining us for the first time, or if you're a regular, a friend of the foundation, and you need a friendly reminder, here's how the show goes. Go ahead and send in your questions. Dr. Naraev will try to get to as many of them as possible. We'll try to get to as many of them as possible, but inevitably, we run out of time. We would respect everybody's time, our guests, yours, mine, everybody's. We keep this at an hour sharp. So if we don't get to your questions, please know that you can follow up with the Carcinoid Cancer Foundation either here on their Facebook page, you can message them or email them, visit their website at carcinoid.org, and they will get you the information, or the person who will give you the information, I can assure you of that. So if you don't get your question answered, make sure that you follow up, because ultimately, that's our goal. That's what we're trying to do here. So 2 asks that I say at the top of each program. 1, what's so unique about this program is it's virtually a one-on-one session with a specialist. This is such a great opportunity, such great value for you and any other patient that you know, or any caregiver, anybody involved with this disease. So if you know someone that would benefit from this, go ahead and tag them in the comments, share this video to their page, let them know what's going on now live so they can come across and get their questions asked and answered, hopefully. If they don't make it, of course, they can watch the playback of this as well you can, but you kind of miss out on that opportunity to get your question across. So let people know if they're around. And secondly, you all have been doing such a good job of this, helps me do my job better, which is to serve you. If you see a question in the sidebar there, that you also have, you're also interested in, you can like it, love it, any of the reactions that Facebook gives you or offers you, and it'll allow me to see that there's a demand for that question. Like I said, we have a ton of questions. We don't get to them all. So if I see that 7 people have liked that question, I know there's a demand for it. It kind of upvotes it, and it lets me know that we need to get that question across. One final announcement I always like to ask, have you downloaded CCF's free Net Cancer Health Storylines app? This app makes it very easy to record your symptoms, medications, nutritional concerns, your moods, and everything else. So if you haven't, go check that out. Go download that. We'll put a link in the comments, and anything else that Dr. Naraev mentions today, we'll put that link in the comments too. So if it's a resource, you can access it easily and you don't have to go to Google and search for that. And actually, I said that was a final announcement, but I do have one personal announcement that I'll just take a brief moment to deliver. You can see I'm wearing my little casual shirt here. That's because after this show, I'm headed to the beach. Today is my wife's birthday. So we're celebrating that. And we announced that we are having our 2nd child due in July. So a lot of room for celebration. It's not about me, but I would be remiss if I didn't mention that to you because I feel so connected with everybody here in this community. So there's a beautiful picture of her up today on my Facebook page if you want to go check that out. I'm not going to bore you with that now because we got a show to do. So let's get into the show. Dr. Naraev, so I asked you kind of, about what transitioned you into this. I always am also interested in when you started working in this disease, what were some of the initial, and they may still be there with you, but the initial challenges that you noticed that were unique and specific to this disease? You had studied oncology, but we know that this disease, this kind of cancer is really unique. What were some of the things that you noticed that were like, oh, this is something different?
Well, there is a reason the zebra color is the color of this cancer. So it is indeed a zebra. It's rare. It's not your typical cancer. Probably what was most interesting to me, at least initially, it still remains interesting, is that in many cases, it's a very slow cancer, which in a way is a good thing because even people with stage 4 metastatic disease live a long time, which brings its own challenges because you don't want to run out of the bullets in terms of treatment options in the middle of the fight.
Good point.
So as well, the treatment options, especially as time progresses and we learn more and more about this cancer, are not the same as for other cancers. For example, for majority of other cancers, for stage 4 disease, we do not consider debulking. For neuroendocrine tumors, this is one of the very first things you do consider when you see a new patient with stage 4 disease, debulking surgery. We know now that for neuroendocrine tumors, if you remove the primary tumor, even in stage 4 disease person, the person likely to live longer. As well, what is interesting to me is that there were not many treatment options. Now I'm realizing that I was there when everolimus was approved, and it was such a big deal. It was such a big deal. I still remember patients who were on octreotide pump. So it was not that common, but I remember those patients. So significant progress was made. But what was interesting initially, it still remains very interesting now. And the more we learn, the more interesting it becomes. And there is a reason this is one of the cancers, actually probably only one cancer when people are having curative surgery and curative other treatments, the follow-up is not 5 years, but 10 years. It's a bit unusual, and it presents its own challenges.
Got it. Got it. Well, as always, and as expected, the questions are rolling right in. And so I want to make sure that the people get the value that they came for. So we're going to go ahead and start taking questions from them. I could talk about this stuff all day, but it's not about me. So Tracy says, and this is a common question that I hear, especially it's very topical. What are the recommendations for COVID vaccine for carcinoid tumor patients or neuroendocrine tumor patients? Thoughts about that?
Well, short answer, go get it. Longer answer is we do not know. Because as you know, nobody looked into that. The NCCN guidelines that were published, I believe in February this year, indicate overall that patients with cancer, with certain very rare exceptions that don't pertain to our situation, specifically stem cell transplant patients and patients treated with CAR-T, but that's beyond the point. But recommendation is to get vaccination. And patients ask this question all the time, the time. And overall, the common knowledge is go get it. So and there are many secondary questions. What about the status of the immune system, et cetera, et cetera. But actually, even NCCN guidelines specifically mention that who should get those vaccinations. People with cancer on treatment for cancer, not including hormonal treatments, because as we know so far, treatment in our situation with somatostatin analogs, which very close to hormonal treatments, does not significantly, to our knowledge, affect the status of the immune system. So from that standpoint, we fully expect that patients that are on those treatments would mount great response to vaccination. So, but the truth is nobody looked into that. But so far as the data comes in, we do not see anything that would suggest that there are any significant concerns related to patients with neuroendocrine tumors and vaccination against COVID.
Good, thank you. And you're right. Here on the show, we get questions pretty much every week about it. And I'm sure you're getting them too. And yeah, I mean, it's a justifiable concern. I understand it's a scary time for all of us, but especially patients. So thanks for your question. Next question from Tracy. So Tracy says, my daughter is 21. What tests can she do to see if she's at risk for carcinoid syndrome or eventually carcinoid tumors? Now, she doesn't specify if there's symptoms. So maybe and I'll let you decide how to field this, but maybe we could just talk about in general, let's say if you're having symptoms, what test might one seek to take?
Well, okay. I wonder if the patient might be, is this as a patient? Don't want to put assume,
well, her daughter, it seems like it seems like her daughter might be a patient. I'm not exactly sure.
The daughter might be patient or the person might be the patient. Question is if the daughter has higher chance of those cancers. That's a different story. We will talk about it. But in terms of symptoms, that's a big topic. That's one of the issues. Symptoms are not very specific.
Right.
And frequently it takes long time, literally years to get to the diagnosis. And unfortunately, there are no screening tests. Let's say for prostate cancer, we have PSA that is well established and you can check simple blood tests. So you can have higher or lower level of suspicion. For neuroendocrine tumors, I see that in the community, people very commonly check chromogranule levels, which is not a screening marker at all. So occasionally people check 5-HIAA in 24-hour urine collection specimen, which is probably more specific. Occasionally people check serotonin levels. But overall, if there are symptoms, you need to go to see a specialist where potentially the symptoms belong, so to speak. If this is diarrhea, probably starting with gastroenterology consult is a good starting point. So because very frequently many things could be found during evaluation, which would probably include endoscopies, and very likely that it might include conventional imaging like CAT scans of the abdomen and pelvis or MRIs, and that's usually how tumors are found. So, but again, it all depends on the symptoms, because again, symptoms are very non-specific.
Yeah. So let's take, because I think you had a good point. You may be right. Let's take the other option of that question. If Tracy is the patient and she's concerned about her daughter, so this would be, I guess, some genetic testing or something like that. Is there some tests that she could do to see if it is something that is running through the bloodline?
Well, the situation with genetic testing is as follows. Usually, we try to have genetic evaluation for every new patient who is diagnosed with neuroendocrine tumor. And what genetic evaluation includes is essentially our geneticists would talk to the patient, compose a family tree, and see if things in the clinical history and on that tree make sense for them to proceed with testing. And then they will decide what exactly to test for. Because as you know, now there are hundreds of different tests. And it used to be that oncologists were ordering genetic tests all the time. Now we have geneticists to see patients and make those decisions. And then usually when the patient who actually was diagnosed with tumor was found to have certain mutation that we think might be related to this tumor, then children, if they want to be tested, or other relatives that if they want to be tested, would be tested for this very mutation that is already known. Mm-hmm. So I'm not aware of any guidelines that would recommend, blanket testing for everyone who wants to for any possible mutation under the sun. However, one size never fits all. And if a person has family history of cancers, including neuroendocrine cancers, but no personal history, and there is concern that might be something is related to inherited mutations, then it would probably make sense to have genetic counseling, not testing, but counseling. When you sit down, as I mentioned earlier, you talk to the geneticist, come up with the family tree, and then follow the advice. In some cases, testing would be indicated. In some cases, it would not be indicated.
Awesome. Thank you. And thanks for your question, Tracy. Hopefully that helps. And for you all at home, if you joined us late, we're here with Dr. Boris Naraev talking about neuroendocrine tumors. This is Luncheon with the Experts. Welcome. And I noticed that a few of you, when he was giving his previous answer, hit the like button or the love button. You see these little emojis floating by. That's a great visual cue that you're getting some value. So if you are getting information that's helpful to you, go ahead and do that. It lets me know that, hey, we're doing our job well. So next question, which is also about carcinoid syndrome, from Patty, who says, basically, what causes an itchy rash that's not caused by an allergic reaction? So is that a symptom of carcinoid syndrome? And if so, is there any way to treat it, or what's the best way to treat it?
Well, rash could be. It's not very common. It's not very common component of carcinoid syndrome, but it could be, because as you know, neuroendocrine tumors could produce a very long list of very different substances, and some of them could cause skin rash. But how high is the chance? Not very high. So, but then again, if something is not right, it should be checked out. It should be checked out because you do not know. Because as an example that I give to my patients, I can tell the short story of one of my patients. Please. Who was an 82-year-old gentleman, and for the last 10 years, I believe, before the presentation, before initial evaluation here, so he was the favorite grandparent of his grandchildren because he could do the trick. And the trick was when any grandchild comes to him and says, show us the trick, he would sip any amount of, probably like a couple of ounces of any alcohol. And within 3 to 5 minutes, he would turn absolutely purple. He would flush. And kids were happy because it was funny when grandpa turns red. And he was okay with that. He enjoyed the popularity, etc. And I asked him, I said, don't you think it's not necessarily normal? Did you ask your doctor about it? He goes, yes, I talked to my primary care doctor. And what did he tell you? Well, he told me to stop drinking alcohol, so you will not flush. So that was the end of this story. So it turns out that the gentleman had widespread stage 4 neuroendocrine tumor of the small bowel origin. And the flush, he didn't have diarrhea, he didn't have wheezing in the lungs, he didn't have skin rash. The only thing he had, he could do the trick. Alcohol provoked flushing. So, but eventually, when something else happened and there were symptoms of small bowel obstruction, medical attention was turned to that, scans were done, masses in the liver were found, etc., etc. So that's why when something does not make sense, you need to look into that. You need to talk to a specialist. Yeah. So that's why rash chances are not very high, but again, it shouldn't be there. It shouldn't be there. So from that standpoint, it would make sense to be evaluated. In terms of treatment, you need to know what is happening before you can decide how to treat.
Absolutely, absolutely. Next question from Julie. Julie says, my son was just diagnosed. Sorry to hear that, Julie. The tumor was found by pathology after he had emergency appendectomy, which tends to happen. We have an excellent surgeon. Okay, here's the question. And this may not be something that you have the answer to, Dr. Naraev, but someone out there in the comments might. So I think it's still important to get across. I was wondering if there is a teen support group. I think that's such a good question. Seems like there aren't many, if any, support groups for this disease. That, however, I can answer, Julie, there are a lot, and we'll try to get you some information on that in the comments. I don't know about the teen support groups for this, and I think that would be very important because it's a different thing psychologically for a teen. Dr. Naraev, do you happen to know of anything like that by chance?
Well, patient support groups is actually the cornerstone of taking care of patients with neuroendocrine cancer. This is one of the most important things, and that's actually what makes treating this cancer unique, because patient support groups are extremely important, especially for newly diagnosed patients, extremely important. So I'm not aware of any support groups that would be specifically designed and working with teens only, because it's reasonably rare to see this type of tumor in younger patients. But what I would suggest, practically every state has support group. So, and there are support group with national reach. And so I would like to suggest that essentially Google it up. There might be something, maybe some group on Facebook or somewhere else on social media.
Yeah, definitely.
But again, in terms of teens, it's probably shocking. I would not be surprised, because diagnosis of cancer in a young person, it's always a shock. Not that it's not a shock in an older person, but young people react to that very differently. So it might actually make sense to talk to people who are there for a long time. So I would start with just regular support group, because people who've been there before you and still there and have experience, they can help. They can help.
No, I think
in fact, I'm not sure if you guys talked about it or not, but Healing Nets Foundation, just recently, I think in January, they published special booklet for about neuroendocrine tumor journey. And it's written for the newly diagnosed patients, and it's written by the patients who've been there before and who are there. And it's very helpful. It's very good source of information. I know, in fact, I have it just in case here. Many of you probably saw it. I'm not sure if you can see it well. And it exists on their website in the PDF form. So this is very good starting point. And then if there is a group for teen support, that would be great, because it's very unique situation.
Yeah, if I had to guess, there's obviously there's plenty of support groups for neuroendocrine tumors. There may not be one, like you said, it's so rare for teens, but I'm sure there's like a teen cancer support group, or because of the uniqueness of this cancer, it may be like a teen chronic condition support group, which could apply as well, because it's kind of this invisible thing. I will say that support groups, as to echo what Dr. Naraev said, are so important for this disease, and we've done videos about them and their importance and how they've helped people. So definitely encourage you seeking that out. We also have done videos on teens and children who have been diagnosed with neuroendocrine tumors. So you may be watching some of those. You can go to our videos tab and scroll through there about 2018, 2019. May be helpful in terms of a younger person psychologically navigating this disease, because I know there would be other issues presented for someone. Obviously, like you said, Dr. Naraev, it's never not a shock, but being 16 and dealing with this, I still feel is different, just because the perspective on the world is different.
And if I may add, as I'm still thinking about it, maybe it would make sense as a starting point, look for support groups for patients with MAN syndromes. Because we would have higher chance of having younger people involved, not necessarily with cancer, but with MAN syndrome that would predispose you for cancer. And at least in terms of age group, it might have higher chance of having those people there.
Yeah, great point. Thank you for that. And thanks for your question, Julie. Hope that helps, but keep leaning on the community. This is what we do here. Besides giving you information, is providing this community, and everybody's experience is important, and everybody is very welcoming and helpful. So reach out to people. They will come to your aid. So next question from Sarah, maybe too case specific, but maybe you can still field it and give her some guidance. Sarah has not had any surgery. She's had a year of chemo. and PRRT, grade 3 Ki-6725, well differentiated, liver, small intestine, bone. Her question is, am I still a candidate for surgery, or what would be the next treatment? So I know that's very specific, but
it depends on the situation.
yeah.
But usually we always consider removing the primary tumor, especially if this is neuroendocrine tumor of the small bowel, because risk of obstruction is probably higher when the tumor is in place. As well, we always consider debulking, means removing as much of metastatic disease as possible. Because we used to think that if you remove 90% of all the disease, which is mostly related to metastasis in the liver, because that's how people usually get in trouble if disease progresses. But later we learned that it's not necessarily have to be 90, it could be 75, and people still live longer. So especially if this is symptomatic tumor, and by removing the bulk of the hormone producing cancer tissue, you will decrease the symptoms. So, but this is the overall approach. Whether it's technically possible, this is different story. But as I said, each time when we see a new patient with stage 4 disease, we always consider surgical removal. We always ask surgeons to tell us, because I personally never make those decisions because it's not my specialty, and we have amazing surgeons, and it's very important to talk to a surgeon who specializes in this type of cancer and in those types of surgeries. So, but if it's technically possible, I don't know the details of the case. Obviously, it will have to be considered. At least it needs to be discussed, so you will have some clear understanding. If it's possible, that's question number one, because if it's not technically possible, let's say tumors are close to the vessels, etc., you cannot remove them, or too many of them, that's one situation. But if it's possible, then the question is if it makes sense. So, but this is something that needs to be discussed with your neuroendocrine cancer specialist and with your surgeon. But of course, what will come into play in this situation, that previous radiations, like radiation delivered by PRRT, previous chemotherapies that could potentially affect kidney function, liver function, diminish bone marrow capacity, et cetera, et cetera. So those are details that need to be looked into when you see the patient. But usually, initially at least, everything is on the table.
Got it. Thanks for your question, Sarah. Hopefully that helps. Next question from John. John says, my wife's started in the small bowel, moved to the liver where there are 2 tumors, and then moved to the heart where it damaged the valves on the right side. So tomorrow she'll get her second monthly long-acting shot, and they're planning to replace the valves in the near future. But basically, John's question is this common for this type of spread to the heart? Is this something that you tend to see with neuroendocrine tumors?
That's a good question. And I think there are 2 questions in one. First, a possibility of neuroendocrine tumors to metastasize into the heart and its structures. And second, and I think that might be the case, carcinoid heart disease, which is a completely different animal. So, and I suspect that might be the case, because we do occasionally see neuroendocrine tumors metastasize into the heart. It's either pericardium, which is the sac that surrounds the heart from outside, or sometimes it could be actually in the heart muscle. Usually there is no treatment for that because, as you know, in most cases, neuroendocrine tumors are very slow. And we usually monitor those tumors in the heart with imaging and 2D echo, which is ultrasound of the heart, etc. But they usually don't involve the valves. What I think might be happening in this situation, and that would be very, very typical presentation, biochemically active neuroendocrine tumor of the small bowel that is metastatic to the liver, and it is producing serotonin. And we know when there are high levels of serotonin in the bloodstream, it damages the valves. And what the person is describing, the damage to the right side of the heart, is actually very, very common. So, and when valves are damaged significantly, then the treatment, you are correct, the treatment is usually to replace the valves. So, and sometimes people need to have more than one valve replaced at the same time. So, and we do see patients in this situation, and it's usually a challenge because if, let's say, in this situation, only 2 tumors are in the liver, you are naturally wondering, could they be removed? And then that would decrease serotonin production, hopefully, and less damage to the heart, because problem is even when you replace the valves, unless this is a mechanical valve. So there is risk of development of carcinoid heart disease again several years later. There is research that looks into how to prevent it with the use of certain medications. For example, telotristat, because concept is what if we keep levels of serotonin low, would it at least increase the time to have significant time damage, and we have that time, or if it will decrease the chance significantly, we do not know. So, but what is probably happening in this situation is probably heart damage related to high levels of serotonin. And this is always challenging situation. Just recently, I saw a patient who was perfectly fine, and then she was diagnosed with a neuroendocrine tumor and obviously carcinoid heart disease, and literally over a period of few weeks, she went into heart failure. And the question is, so what do we do first? Do we fix cancer? Do we fix heart? Common sense is you need to fix heart, because otherwise your risk of troubles when you have anesthesia for surgery related to neuroendocrine tumors will be very high. So this is very challenging situation, but usually if valve replacement is needed, that's the way to go. And I know that Mayo Clinic in Rochester, Minnesota, where great Dr. Havdanasan practices, that they do have carcinoid heart disease clinic. That's their specialty. That's what they do every day. And usually we ask them to evaluate our patients if possible.
Yeah, that's a tough decision. That one hit close to home because my father had a similar situation, and I remember the doctor struggling with that, but landing on the same thing. Well, we have to protect the heart first and put the cancer second. But John, good luck to you and your wife. Thanks for your question. Hopefully that helped. And like I said, if you're new to this community, please talk to the other people that are here, and they'll help you. So Dr. Naraev, next question from Jenny. Jenny says, my mother's a lung net patient and currently in Taiwan. And the doctor in Taiwan is saying it's not operable, and PRRT isn't currently available in Taiwan. I wasn't aware of that. So we are trying to get her back to the States for treatment, but it's not possible now due to the pandemic. This is happening as well for people. The doctor tried chemo and it made her extremely ill. Now she has pneumonia. At this point, is there any suggestion or advice that you would have for Jenny and her mother who don't have access to PRRT? They're stuck in Taiwan with a lung net. There's a lot in that.
It's a lot. It's a very difficult situation. Well, which brings big question about PRRT in patients with neuroendocrine tumors of the lung. As you know, the clinical trial that led to the approval of Lutathera, which is the only drug approved in the States, did not include patients with neuroendocrine tumors of the lung. Well, to that extent, they didn't even include patients with neuroendocrine tumors of the pancreas, but that's a different story. Right. So, but we do have data that if neuroendocrine tumor of the lung has expression of somatostatin receptors, PRRT might be effective. Dr. Havdanasan and I published a review paper that put together all the information that was available at the moment, and we know that it is working. So question is if it's truly indicated. I'm not sure why exactly chemotherapy was done, because question always is, as many in the neuroendocrine tumor community know, second or third question asked of a new patient when they go to patient support group, what's your name? And the second question, so what's your Ki-67? Because Ki-67 index, or percentage of cancer cells that are dividing, is very important. The higher the number of cells that are dividing, the more aggressive the tumor is, and probably the higher chance that it will respond to chemotherapy. However, if let's say Ki-67 more than 55%, it's not necessarily guaranteed that PRRT would be effective. So, but in the meantime, I understand the situation is the person is there, PRRT is recommended, and cannot be done. So then potentially standard of care could be considered, which is everolimus, unless we are dealing with high-grade neuroendocrine tumors. When there is lots of dividing cells and it's rapidly progressing tumor, this is different story. Then usually combination of chemotherapy with some sort of immunotherapy is suggested. But overall, if this is not high grade, I think everolimus might be considered in this situation. But again, without knowing all the tiny details of the story, it's difficult to definitively recommend something.
Yeah, understood. But thanks for that. That was helpful, I think, and hopefully it was Jenny. Jenny, I'll also make mention that we did a video recently at the end of last year, maybe beginning of this year. The 2020 made things kind of a blur, but pretty recently in the past few months on lung nets. And it's a pretty thorough video, about 15 minutes. It's under the videos tab. So that's maybe another resource that you could check out, because lung neuroendocrine tumors do present some their own unique challenges. They're not exactly the same as nets of the gut. Okay, moving on. Agnieszka, hope I'm saying your name right. I was diagnosed with a net tumor in the head of the pancreas. It is 1 centimeter large. Should I have surgery or any other type of therapy?
Well, for neuroendocrine tumors of the pancreas, if they are reasonably small, occasionally, provided they're not metastatic, occasionally observation is okay. You just watch, and if you see that watch means you're doing either MRIs or CAT scans every so often, usually every 3 to 6 months. If everything is stable and it's not bothering you, either due to location and mechanical obstruction, let's say, of the bile tree, and people develop biliary tree obstruction and they turn yellow, et cetera, et cetera. So if it's not bothering in that way and the tumor is not biochemically functioning, means it's not producing any substances that could potentially give you some symptoms, from diarrhea to issues with blood sugar control, either too high or too low. So occasional observation is fine. The question is, again, what is the Ki-67? I assume it was proven on biopsy, so usually it's standard of care to calculate Ki-67 index, because if it's reasonably low, it's probably okay to watch, but if it's reasonably high, then potentially surgery will have to be considered. A problem with neuroendocrine tumors located in the head of the pancreas is that usually the surgery that is being considered is so-called Whipple procedure, which is massive intervention on its own. And essentially, in many cases, people might have consequences after the surgery just related to the procedure, because it's a very significant procedure. So that's why I think it would make sense to ask for evaluation by a surgeon who specializes specifically in neuroendocrine tumors, and hopefully neuroendocrine tumors of the pancreas. So, and it's always good to ask for a second opinion. I'm surprised nobody asked about second opinion yet, but second opinions are good for you. And then if you talk to 2 or 3 experts and everybody tells you the same thing, it probably makes sense to do so. But overall, for smaller tumors, observation is fine, as long as the Ki-67 or aggressiveness, so to speak, of the tumor is not very high.
You know, I think that a lot of our community here, the patients are very well educated about this disease, and they're all great advocates for themselves. So I think a lot of people know to seek out second opinions and third opinions if it's necessary. And what I really like is that the doctors like you dealing with this disease are also encourage that. They don't feel threatened or anything like that. They encourage, you know, the second opinion. And I think that's because of how unique this disease is. And everyone knows that one way might not be the way for everybody. So folks, if you have joined us late or are just joining us, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. Today, our guest is Dr. Boris Naraev. We are here every Thursday from 12 p.m. to 1 p.m. Eastern Time. We've been doing this for almost a year. We started in July 2020, and we have no signs of slowing down. We love the feedback from you all, and this is what helps us continue the program, and we come here to bring you value every week. 2 ways that we do that. 1, information from an expert like Dr. Naraev in today's episode, and 2, the community that we help cultivate here. So I encourage you, talk to each other, share their stories. In fact, Lorraine said a few comments back that we had mentioned support groups early in the program, and Lorraine just said that support groups are so helpful for patients because they give us questions to ask our doctors. I think that's such a great point, as well as emotional and psychological support. Is sharing stories with each other, sharing your own experience is really going to help people, you know, see their path forward, because there is not one path forward. And so I think that's such a great point, Lorraine. I appreciate you mentioning that. And for anyone who's new to the show, new to this journey and this disease, The community is amazing, is outstanding, and I highly, highly recommend you lean into that. There's a lot of value that will come from it. So Tracy says, is there any special consideration or specific information on losing weight with carcinoid tumors? I was rejected for bariatric surgery due to my carcinoid.
Is the question how to lose weight with carcinoid, or
yeah, is there any special consideration or information on losing weight with carcinoid tumors?
Well, it's a difficult question because usually the rule of thumb for majority of patients, we don't want you to lose weight. Because usually in the settings of metastatic disease, if patient starts losing weight, frequently it's indication of disease progression. And overall, it's not a good idea to not to have good nutrition and to lose weight. However, if the person is overweight, and then there is carcinoid syndrome, and looks like the bariatric surgery was not possible because of carcinoid, it depends. If this is stage 4, it's one situation. But usually, neuroendocrine tumors are well behaved in majority of cases. So people usually live long time. And this question comes up very frequently, not just with bariatric surgery, but let's say a person has stage 4 disease that is stable for 3 years, and now the person has prostate cancer, unfortunately. And urology people call you and ask you, how aggressive should we be? And we usually tell them, be as aggressive as you can, because life expectancy is very much okay, even with stage 4 disease in this very situation. Or even bigger question, kidney transplant, because that is a very big question, because technically this is stage 4 disease, which is otherwise is a contraindication for organ transplant. But again, neuroendocrine tumors are a little bit different. People live many, many years frequently with this cancer, and maybe transplant is making sense and it is safe to do. But in terms of bariatric surgeries, probably weight loss, if it's needed, because the person is overweight and there is carcinoid cancer and carcinoid syndrome, probably usual recommendations would apply. I know that bariatric surgeons usually want to see some weight loss just from diet and exercise. And if the patient shows commitment and it works, then they will consider surgery. But again, it's difficult to answer without knowing all of the details, But again, it's difficult. It's difficult. We don't know the stage. We don't know if the tumor is biochemically active. But overall, diet and exercise help in majority of cases as a good starting point.
Okay, moving forward, Stacy, and it seems a lot of other people have this question. Is it true that carcinoid patients are 20% more likely to develop another form of cancer? If so, can molecular genetic testing determine what cancers may be specific to the individual?
That's a good question. So we still think that majority of neuroendocrine cancers are sporadic, means just bad luck. That they're not inherited. So whether they have a neuroendocrine cancer increases your chance of other cancer, not very likely. There is not that much hard data that would show that. So however, we always tell our patients that unfortunately because usually it's other way around. So the patient think, all right, I got this cancer, I don't need to do anything else in terms of screening for other cancers. And we usually tell patients that, look, unfortunately we have this cancer, but it does not decrease our chance of having other cancers. That's why screening needs to be done for prostate cancer in men, for breast cancer in women, for colon cancer with colonoscopies in everyone, et cetera, and of course screening for skin cancer. Speaking of living in Arizona, very important, especially when there is that much sun exposure. But in terms of molecular testing, again, it's impossible to predict who will develop what kind of cancer and when, and if at all. So far, I'm not aware of any readily available testing in that regard, especially when we are talking about sporadic cancer. That's why recommendation is just regular screening that needs to be done. And thinking outside of the box, in majority of cases when people have neuroendocrine tumors, let's say a patient had neuroendocrine tumor, it was completely resected, let's say stage 1, 2, or 3, not metastatic, you still have to follow the patient for 10 years. And you still follow the patient with imaging every 6 to 12 months, depending on the insurance coverage. So not that we are looking for other cancers, but if something were to pop up, God forbid, you would see. It's not like we're only looking for neuroendocrine. When something is not right, it will have to be addressed. Yeah. So that might indirectly help. When people have stage 4 cancers, scans are done more frequently. And again, if something is not right, you will be able to see. But this is the imaging. It's not molecular testing.
Got it. Thank you for that. So question from Lorraine. This is an interesting question. To the doctor, Naraev, have you heard about any patients complaining about teeth hurting and joint pain? Now, I have heard people mention joint pain, but Lorraine says there are so many of us NET patients that are complaining about it currently. I think this needs to be something that needs to be looked into. So joint pain and teeth hurting. Have you heard of any of this?
Absolutely, especially joint pain. Joint pain is actually a known side effect of somatostatin analogs. So, and since majority of patients are treated with one of the somatostatin analogs, so actually pain, especially pain in the small joints, could be related to that, not necessarily to cancer itself. Because I don't think that we in our community, we have many patients who do have cancer and not on any treatment.
Right.
So if we were to take this subgroup of patients and see what the percentage of people with pain in the joints, that would be a different story. Yeah. But most of the patients are treated, and majority of patients with low-grade disease are treated with somatostatin analogs. And yes, pain in small joints is a common side effect. That's probably, speaking of chicken or the egg. So this is probably related to the treatment, not necessarily to the cancer.
And you think that's the same thing with the teeth?
This is not as common. People do complain occasionally. It could be that. Biggest concern when you start talking about teeth is if a person has metastatic disease in the bones, and the patients are treated with so-called bone hardeners, which is usually denosumab or zoledronic acid in this country. One of the possible side effects is so-called osteonecrosis of the jaw or rotten jawbone. So, and maybe there is something and people might have discomfort related to that. This is right now just pure speculation on my end.
Yeah.
So that's why with teeth, it's a little bit less clear, but pain in small joints, it's common. It's actually more common than people think.
Any advice on how to navigate that? Because, taking them off the medicine is probably not the right choice for them. So anything they can do to help kind of alleviate some of that pain?
Well, first, we need to make sure that there is nothing else, that this is truly could be attributed to the injections. You need to make sure there is no arthritis, the most common type, degenerative joint disease, or rheumatoid arthritis, or something of that nature. Okay, and then if we truly believe that this is related to the injections, I believe I have 1 or 2 patients that essentially were forced into stopping the treatment just because of that. It was that bad. But in majority of patients, just regular Tylenol or ibuprofen might help, depending on the situation. So occasionally, when it's really bad, what we can do, we can try to switch around. If, let's say, the patient is long-acting octreotide, you can switch the patient to lanreotide and vice versa. Sometimes it helps, even though the 2 drugs are close to each other biochemically, they're not the same. And sometimes people have reactions to one and they don't have reaction to the other.
Got it. So folks, we have just a little bit more than 10 minutes left. We're going to keep churning and trying to get through all your questions. Thank you so much for everyone attending today. Next question from Marcia. Dr. Naraev, Marcia says, what is the best way to control intestinal gas as a condition of carcinoid syndrome?
Intestinal gas. So I wonder if patient has diarrhea as well, and it depends on the treatments, because it's a big topic. So speaking of which, I prepared myself for the meeting. Probably most of the viewers are familiar with this book. This is one of the best books that is specifically written for the patients who have carcinoid syndrome and carcinoid syndrome related diarrhea. It's very good reading. And I think it's still available. People can order it online, and it's free, actually. So, and this is from manufacturer of telotristat. Okay. So I would suggest that first up, read the book, try to figure out what subtype of 4 different subtypes of diarrhea you might have. And then dietary adjustments could help. So in terms of gas, what frequently is being overlooked is the fact that, again, somatostatin analogs, lanreotide or octreotide, could suppress the function of the pancreas. And people develop relative pancreatic insufficiency related to that, which means pancreas does not make enough enzymes to digest fats and proteins. And it could give you gas, it could give you diarrhea, it could give you what they call steatorrhea, when there are droplets of stool in the toilet after each bowel movement, when the oil is coming out, literally, fat is coming out. So this is the first thing to look into. If this is indeed the case, what we frequently use is substitution of pancreatic enzymes. It's either a medication called Zenpep or medication called Creon. So, and it could be always tried and see what happens. And of course, anything that you could think of over the counter, Mylanta gas, Gas X, etc., you can try. But the first thing to consider probably would be pancreatic insufficiency, especially if the person is on a somatostatin analog, especially if there was previous surgery on the pancreas, which decreases the volume of the pancreas that makes the enzymes. And as well, other causes not to be overlooked because it might not even be related to carcinoid syndrome. Some people might have, for example, bacterial overgrowth, and it could be treated, bacterial overgrowth in the small bowel. And that's why it's very important to have good established relationship with your gastroenterologist, because they are the people who could proceed with workup for other causes of excessive gas. So, but these are the steps that I would consider thinking about pancreatic insufficiency related to the injections and maybe previous surgeries, reading the book and trying to figure out if dietary adjustments might help, and talking to a gastroenterologist to look for other possible causes of gas formation.
Got it. Thank you for that. Question from Florian, which we've already addressed. I just wanted to make mention to him. Is PRRT therapy good for tumors of the lung too? As Dr. Naraev said, it wasn't approved for lung nets, but I just wanted to say, Florian, we do have a video on lung nets. You can go to the videos tab. And if you rewatch this video, you can see what we mentioned about that earlier. So Dorothy says, what is considered high levels of serotonin? Is it twice normal, 3 times normal? At what point is it dangerous to your heart?
That's a good question. In terms of when it's dangerous to a heart, the truth is nobody knows. So, and in terms of levels, we know that Dr. Pommier showed on his research that when levels of serotonin close or exceeding 1,000, then it's patient might have very high risk of carcinoid crisis. That's another big thing in the neuroendocrine cancer world. So, but what's considered to be elevated, technically speaking, anything that is above the upper limit of normal. But it depends on the lab. Of course, I cannot give you any certain numbers. But what is more important is to actually check 5-HIA in 24-hour urine, because just checking serotonin level in blood might not give you the full picture, because, you know, serotonin is short-lived. And if the tumor does not produce it consistently every minute at the same rate, so essentially levels in blood might go like this. And if you draw blood at the low point, you might not have the right answer. However, when serotonin degrades down its normal biochemical pathway, 5-HIA is being formed. It's much more stable compound, and you can measure it in 24-hour urine. If this is elevated, and again, depending on the lab, it's a different number. If 5-HIA is elevated, and it does matter by how much, so that then it's the reason to look deeper into the situation with understanding, because I see it frequently in the community. People just order 5-HIA and do it, etc. A person will have to be put on special dietary restrictions for 2, 3, occasionally 5 days before the urine collection starts, because certain foods could increase the levels just because they have too much serotonin on them, or other compounds that could be made into serotonin, and then numbers might be artificially high, and that's why the proper diet before urine collection is needed.
Got it. Okay, moving right along. We got about 5 minutes left. Let's keep pushing forward. Melvin says, does sandostatin LAR cause blood sugar to raise? to elevate. My wife's went from 80s to 90s to 120s and higher. And it seems like a couple other people have this question.
Yes, this is actually one of well-known side effects of somatostatin analogs. It's not just octreotide LAI related.
Mm-hmm.
It might affect blood sugar levels. So in majority of cases, if it were to happen, it would increase the blood sugar level. However, in some patients, it could cause drop in blood sugar levels, frequently unsafe drop. It's not very common. What we see in real life that patient might have higher blood sugar levels than before. And if the patient has pre-existing diabetes, so it makes things challenging. But in this case, we work very closely with whatever doctor or whoever doctor controls the diabetes for the patient, either his endocrinologist or his primary care physician, because sometimes increased doses of the diabetes medications might be needed. But this is a known side effects, and we are well aware of it, and we monitor very carefully for that.
Got it. Thank you. Jane says, does shortness of breath when climbing stairs, but not when walking long distances, only when climbing stairs, does that account for, or is that coming from lanreotide as well? This is in reference to something we said earlier.
No, I would expect that everyone who climbs stairs would have a little shortness of breath. I definitely would. So but it's not necessarily, it would be a little bit unusual. Shortness of breath, no, we don't see it frequently. As you know, theoretically, everything is possible, but practically speaking, when you look at the chances, it's probably something else.
Okay. Yeah, I figured it must be more than normal for her to have asked the question, but I agree with that point that, yeah, any of us, if you walk steps, it will increase that heart rate. So hopefully that helps, Jane. If we don't get to, if you have follow-up questions, please, send them to Carcinoid Cancer Foundation. We'll try to get you the information you needed. John from earlier says, thank you, Dr. Boris, for your reply. It was very well explained. We have a phone meeting tomorrow with the oncologist and you helped. So good news, John. That is what we're here to do. Dr. Naraev, is there anything that you're excited about in the future in terms of some treatment coming along, some development that'll help you do your job better?
Oh God, there are so many things to be excited about.
Let's hear about
it. So much research and so many developments are ongoing. Yes. So of course, there is lots of research into why neuroendocrine cancers happen. That's of course a long shot, but if we learn why and how they develop, we can probably cure them much better. So in terms of treatments, of course, there is a lot of research in terms of PRRT. So PRRT for different conditions, there are clinical trials that are being developed that would look in the use of PRRT for patients with high Ki-67 levels with different cancers of origin, not just small bowel and pancreatic. Then I know there is research into using PRRT for liver-directed treatments. We didn't touch on that, but that's a different big topic. So then there is research ongoing into using not agonists like somatostatin analogs that are currently being used to attach to the receptors when you use PRRT, but rather antagonists, which will have much higher affinity, much higher ability to clutch to the receptor, and that would be exciting development. And of course, the big elephant in the room is immunotherapy, because we used to think that neuroendocrine tumors are what they call cold. There are no mutations and it would not work. But the latest publications by Dr. Halperin of MD Anderson in Houston and Dr. Havdanarson of Mayo Clinic show that actually it's more effective than we think in case of disease progression. So even sometimes in patients who don't have all commonly known changes in the tumors like PD-L1 expression, that was not normally the indication for immunotherapy use, so certain types. So the immunotherapy is probably the new big thing that will be happening soon. And of course, there are many more topics that we could discuss, but all of that keeps us very excited.
Yeah, absolutely. There's a lot going on. And, when you started about 10 years ago in this, I think there was a lot that was happening then. And in these 10 years, I know there's been so much that has helped us diagnose this disease, treat this disease better. So I know that other doctors, other experts and specialists, as well as patients, are really looking forward to some of these new developments to, to help treat this disease better. Folks, before we go, I just got to say, you guys write the best comments. It makes me feel so good. It makes us feel like we're doing our job. And sometimes I like to read these because they're very meaningful to us. So Melvin, who we heard from earlier, says, my wife has been holding off getting a second opinion. However, since listening to Dr. Naraev today, this has made my wife comfortable about going and getting a second opinion now. This is why we love these. Thank you for doing these luncheons. Melvin, thank you. Like, this is why we do it. But we love hearing that from you. And I love that Dr. Naraev has inspired you or helped you and your wife feel comfortable doing that, because as he said, it's so important. And nobody's threatened by this, and there's so many different paths with this disease, and so this is what we're here to do. So I love hearing examples of us doing our job effectively. That's what we're here to do. So everybody, thank you so much for joining us. Dr. Naraev, thank you for your time. I have to echo some of the sentiments from our participants today of how well you explained things. You were thorough, but it was easy to follow and easy to understand, and I just appreciate your time so much.
Thank you for having me.
Absolutely, absolutely. And for folks at home, from our friends of the foundation, thank you as always for joining us today. And we hope that this program helped answer some of your questions. If you have other questions, I know there were follow-up questions and we had a lot today. Again, I reiterate, reach out to Carcinoid Cancer Foundation. You can go ahead and message them here on this Facebook page, or you can go to their website at www.carcinoid.org. I know that Grace on the back end, our COO, has been adding resources. You all have been having questions about the book and about other things, and she's been sending links. So check the comment thread. This video will be evergreen. It'll live here on the page, so you can always refer back to it and see those comments. So I encourage you to do that. Starting Monday, we will republish this video to YouTube. For those who don't have access or don't have a Facebook profile, and so they can see that there. And as always, thanks again to our presenting sponsor, TerSera Therapeutics. We wouldn't be able to do this program without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody. I'm going to the beach. Bye-bye.